Welcome all to MRB recall sessions for this pathology subject. Before starting this session, we'll be happily and proudly say that all the questions asked in the pathology and the clinically applied aspects, all these things actually we covered in our MRB module. And I can show you, it's not merely just saying, I can show you with the proof of the screenshots taken from our workbook notes actually. The MRB notes we have given for our candidates, registered candidates. So I wish and I hope like everyone would have done this session very well. Because as pathology 100 out of 100 like the exact questions, even the exact options actually we have discussed in our sessions, MRB sessions. So let's see, let's go into the session and let's discuss one by one what are all these pathology questions asked. So the first question asked was, disseminated intravascular coagulation is common in which type of acute myeloid leukemia? The options given are erythroleukemia, M3 promyelocytic, monocytic, and myelomonocytic. As you can see this, in acute myeloid leukemia, FAB classification, that is the French, American, British classification, classifies this acute leukemia AML into M0 to M7. So based upon the level of maturation and which type of cells are predominant, so based upon that, we can categorize the AML into M0 to M7. So as you can see from here in our discussion, we discussed that AML M3 AML-M3 that is called as acute promyelocytic leukemia, that is APML. Why it is called acute promyelocytic leukemia? Because in this leukemia, lot of promyelocytes will be there. As we discussed in our sessions, you can see here the promyelocytes of these large cells, leukemic cells, which contains this procoagulant substances. Yes, I hope you remember that we discussed that these procoagulant substances will be released and these are the main reason for this DIC, that is the disseminated intravascular coagulation happening in these patients with acute promyelocytic leukemia. And I hope you remember the mnemonic I told, AML, 3 letters, M3. Remember the 3-letter complication DIC. Yes, DIC is a 3-letter word, AML M3. So please remember AML M3, that is the acute promyelocytic leukemia, as we discussed. It is the actually seen in AML M3. I hope you also remember the thing we discussed, Fagot cells. That is, we can see multiple OIR rods and 5 bodies. So these are the screenshots of our notes to you. And you can see here that exactly the same thing is asked. DIC is common in AML M3, that is the promyelocytic leukemia. So guys, next move on to the next question. Which lymphokine has a strong stimulatory effect in causing growth and proliferation of both the cytotoxic and suppressor T cells? Ideally, it should be a T helper cells, yes, both the cytotoxic and helper T cells, which lymphokines has been a strong stimulatory effect in this thing. So as I used to stress in our module, like this interleukins are actually one of the high yielding topic for whatever exams you take. Absolutely, MRB also has concentrated on this lymphokines, interleukins. Yes, when you see this interleukin 6, yes, interleukin 6, as we discussed in our sessions, interleukin 6 is a acute phase, systemic acute phase response involved in fever, cachexia, and shock. Yes, so interleukin 6 is involved in the fever. So what are the other things I told you to remember in interleukin 6? Interleukin 6 means you will remember in multiple myeloma, interleukin 6, yes, then also in COVID, then also anemia of chronic disease, so, and also in fever. So this interleukin 6 plays a major role in all these conditions. Then what I told you to remember about interleukin 5, I told remember 5 for E. 5 looks like E. So remember 5, interleukin 5 recruits the eosinophils in allergic responses, in asthma. So when there is lot of eosinophils, so you need a lot of recruitment of this eosinophils. Actually, the interleukin 5 plays a major role in this thing. And what I told you about this interleukin 4, guys, interleukin 4 helps in the conversion or helps in the transition of a naive B cell into a naive T cell into a CD4 helper T cell, that is the active T cell. So see, interleukin 4 helps in this. then the ultimate option, that is the interleukin 2, has a strong stimulatory effect which causes the proliferation, growth, as well as the proliferation of both the cytotoxic as well as the helper T cell. So the interleukin 2 is the answer here as discussed. So you can see here we have discussed, and in your notes you can see the exact details of our all the interleukin discussion. Now, another straightforward questions which we got in this MRB exam is about this post-streptococcal glomerulonephritis. So it is, remember guys, this is as I stressed, this is a very important topic as I stressed during our MRB module. So you can see here, what is the characteristic lab finding in the post-streptococcal glomerulonephritis? The options given are decreased C3 or decreased ASO titer or decreased C4 and RBC cast. So RBC cast can be seen in any type of nephritic syndrome. Yes, nephritic means actually it is a nephritic hematuria. So RBC cast actually can be seen. So it is not like a specific laboratory finding for a post-streptococcal. Based on this, we cannot diagnose a post-streptococcal glomerulonephritis. But a very characteristic thing which I told in this post-streptococcal glomerulonephritis is, see here, the complement protein C3 is decreased. C3 is decreased, telling you that the alternate complement pathway is activated in post-streptococcal glomerulonephritis, and that is the reason why the C3 is decreased. And C4 is normal. Why C4 is normal here? C4 is normal because C4 is usually decreased in conditions like SLE, where the classical complement pathway is activated. But in our post-streptococcal glomerulonephritis, it is the alternate complement pathway which is getting activated, and that is the reason why we are having this C3 decreased. And also you can find that ASO titer, that is the evidence of the post-streptococcal glomerulonephritis, streptococcal infection, ASO titer will be elevated. So coming to the options here, C3 we know that is the decreased, ASO titer is increased, and actually C4 is normal. That is a very clinching point for your post-streptococcal glomerulonephritis. And RBC cast by itself cannot say you that it is a post-streptococcal glomerulonephritis. But this finding, decreased C3 with the normal C4, is very characteristic of your post-streptococcal glomerulonephritis. As you can see from our notes, we have discussed detailedly about this polar colored urine seen in this thing, and the age group 6 to 40, 10 years of age group, and the group A beta hemolytic streptococci, that is strains 12, 4, and 1. And what are the antigens you remember, guys? That is the SPEB. What is that SPEB? Streptococcal pyogenic exotoxin B, endostreptocin, nephritis strain associated protein. So all these things we discussed, and you can see the exact words have been asked in this exam. And also, guys, please remember this point: 95%, almost 95% of these children having this streptococcal glomerulonephritis will recover from the renal function, though it looks alarming, like colorectal urine, renal function, all this thing. The patient recover the normal renal function with conservative therapy itself. Yes, I used to insist this in our session. So you can see as this question, exact question is getting repeated here. Now, moving on to this one of the evergreen topic, that is the plant vegetations. Okay, that is the differential. Every exam they used to ask about this different types of vegetations and how morphologically we differentiate between the different types of vegetations. Let's see from our notes what we have discussed. See here, this is the thing we discussed from our notes. When you have small, tiny vegetations, yes. See here, the small, tiny vegetations, warty vegetations, along the line of closure, of the walls, that is characteristic of your rheumatic heart disease. Yes, so small warty vegetations along the line of closure tells you that it is characteristic of rheumatic heart disease. And guys, hope you remember these vegetations which are large, destructive, like a cauliflower, like friable, large, destructive. You can see this destruction occurring in the valvular surfaces. And these are characteristic of your infective endocarditis. And hope, please remember this important difference. Infective endocarditis, the vegetations are infected. Okay, the vegetations are containing bacteria. But in rheumatic heart disease, these are all the sterile vegetation. These are all the sterile vegetations. Yes. And see here, guys, large vegetations along the line of closure. Large vegetations along the line of closure tells you that this will be a NBTE, that is non-bacterial thrombotic endocarditis. Non-bacterial thrombotic endocarditis, which is also called as marantic endocarditis. Marantic endocarditis, which can occur in the cancer hypercoagulable condition. So there you can get large vegetations along the line of closure. Then see here, guys, when the vegetations are seen on the both the surfaces of the valve, you can see here the vegetations are seen on the both the surfaces of the valve. You can think of this condition called as Libman-Sachs endocarditis. Libman-Sachs endocarditis. The vegetations occur on both the sides of the valves, And also please remember, Libman-Sachs endocarditis, LSE. What I used to tell in the class, LSE, Libman-Sachs endocarditis, is seen in SLE, systemic lupus erythematosus. Yes, these are the main four vegetations we have to remember for any kind of exams. As I used to insist, the question asked here, small bland vegetations along the line of closure of the heart walls. Yes, the answer is evident. Bland vegetation, small vegetations, bland. They are very sterile vegetations. They're non-septic, sterile vegetations along the line of closure. Yes, this is rheumatic heart disease. Yes, guys. Now moving on to the next question. Commonest brain tumor in the children of 0 to 14 years. Yes, yes. You want to see the proof like what we discussed in our notes? Yes, see here the exact notes actually we have discussed, where we discussed all the high yielding point. If somebody asks you a general statement, what is the most common malignancy in the brain? You have to tell it's a metastasis. Yes, in brain, bone, lung, liver, in all these organs, metastasis is the first common malignancy, most common malignancy. Then comes the primary malignancy. Yes, as you can see here, metastasis is mostly it is from the lung and the breast. But what is this primary malignancy? In childhood, it is pilocytic astrocytoma. That is, it is also called the cerebellar astrocytoma, as the most common site of this pilocytic astrocytoma is the cerebellum by itself. Yes, so that is the most common primary tumor in the childhood. As you can see here, the most common primary brain tumor in adulthood, that is the glioma. Gliomas are more common. Then the second comes the meningioma. First glioma, then comes the meningioma. Then most common malignant primary brain tumor in the childhood, malignant tumor, okay, it is medulloblastoma, and the most common, very aggressive, that is the most common primary brain tumor in adulthood, that is one of the aggressive manioplasms of the humankind, that is the glioblastoma multiforme, GBM, one of the aggressive malignant tumor. Yes, and as you can see from your notes, like we have discussed even about the pilocytic astrocytoma, that is a CC. I told you to remember, no, childhood tumor. Then cerebellum is the common site, and this Rosenthal fibers has this corkscrew appearance. Yes, CCC I used to tell in the classes. Yes, so remember this pilocytic astrocytoma. So guys, as you can see here, the commonest brain tumor in the child of 0 to 14 years. Yes, obviously now you will know that from our notes. It is pilocytic astrocytoma. Moving on to the next question. The most frequently implicated oncogene in pancreatic ductal adenocarcinoma is, yes. So again, you remember from our notes we have given, we used to give that two tables, guys. One table is full of this list of proto-oncogenes and the associated tumors, and the list of tumor suppressor genes and the associated tumors. And I used to tell that at least minimum one question and maximum 3 to 4 questions you can get just if you memorize this table or column. Just I used to also encourage you people that actually it's not a big task. Just read at least 3 or 4 tumor suppressor gene or oncogenes per day. Then in the 10 days you'll finish everything. Yes, guys, this is quite evident in the 8th exam also. They've asked this question. The oncogene in pancreatic ductal carcinoma. Let's see from our notes what we have given. See, this is this is a part of the table, and you can see from here in the pancreatic tumors, actually the oncogene is KRAS. Yes, oncogene is the KRAS. So the most frequently implicated oncogene in pancreatic ductal adenocarcinoma is KRAS. KRAS. Guys, please also remember the thing which please remember the thing which we also discussed this thing. HER2 new for breast cancer, RET for medullary thyroid cancer, and KIT, GIST, that is the gastrointestinal tumors, and also the seminomas, KIT. And remember ALK. ALK is for anaplastic large cell lymphoma, adenocarcinoma of the lung, and neuroblastoma. KRAS is very important. And also remember HRAS for bladder, NRAS for melanomas, ABL for CML, AML, and I used to say this BRAF. Remember, the BRAF was one of the options. So next time in the next exam, subsequent exams, they can ask you about this BRAF. So BRAF is a highly potential question, guys. So BRAF actually, it is mutated in melanomas, colonic cancer, and also please remember hairy cell leukemia, HCL, hairy cell leukemia, LCH, reverse it, ulta it. Langerhans histiocytosis, HCL, LCH. So remember that this, and also one of the important tumors in which this BRAF is mutated. Then CMYC for Burkitt's, LMYC, small cell lung carcinoma. I used to tell you lot of LLLL. So small LMYC. So, and also easy to remember, NMYC for neuroblastoma. Cycling D1, remember two conditions, multiple myeloma and mantle, MM. Then CDK4 for GBM, glioblastoma and melanoma. So every exam, guys, this is one of the potential area where you will get minimum one question and maximum 3 to 4 questions. Okay, in the applied integrated sort of things, actually these questions can come. Okay. Then another interesting question, actually one of the most expected topic I too used to tell this autoimmunity, definitely they can ask you that question. So again, they've asked about this autoimmune lymphoproliferative syndrome. What is this autoimmune lymphoproliferative syndrome? Guys, as you can see from our notes, autoimmune lymphoproliferative syndrome is actually a mutation because of the mutation in the FAS gene, FAS gene. Yes, this is a condition in which there is actually the mechanism of autoimmunity occurs by the prevented by this deletion by apoptosis. So what happens when a cell is expressing this FAS ligand, this autoimmunity conditions, there will be overexpression of this pro-apoptotic factors because it is an autoimmune. The cells are behaving in a very abnormal manner. When the cells are behaving in an abnormal manner, body don't want that cells to proliferate or survive. So what happens? These cells are not fit to live because they are attacking our own cells. So what happens? The apoptosis is stimulated in our body naturally. So this pro-apoptotic factors like your BIM and a fast ligand pathway. So all these things are getting activated. All these things are getting activated, and the self-reactive cells are being eliminated. So this is the normal thing. So, but if this mechanism is absent, if apoptosis is not stimulated, then these cells are abnormal cells. They will keep on targeting our body cells. They will keep on attacking our body cells. One such example is this ALS, that is autoimmune lymphoproliferative syndrome. So let's see this question. So causes autoimmune mediated anemia, thrombocytopenic purpura, and neutropenia, obviously. So what happens in autoimmune lymphoproliferative syndrome? Autoimmunity is there. Autoimmunity is there. The cells are reacting against own cells because this apoptosis mechanism, this fast gene is defective. So RBCs are attacked. So what happened? RBCs are attacked. Anemia. WBCs are attacked. So neutropenia. Platelets are attacked, destroyed. So thrombocytopenia. And obviously, this is the right answer. And also, you can see here, due to the mutation in the FAST gene. As we all know, this FAST gene is involved in this programmed cell death, that is the apoptosis. To be more specifically, that is, it is the extrinsic pathway of the apoptosis, you can see here. So that is actually the regulating this apoptosis. So this is also a correct answer. But please, guys, be- because of this autoimmune destruction, it is the destruction of the cells occur, but there is no accumulation of this autoreactive B cells. B cells are not accumulated in this autoimmune lymphoproliferative syndrome. Yes, so the option which has to be chosen by you people are massive accumulation of autoreactive B cells. Now, moving on to the next question. The following agents are implicated in microvesicular steatosis of the liver, except. So, as you can see here, we have discussed a lot about the steatosis and also the cirrhosis, different types of cirrhosis. And please remember the commonest agent, okay, that is the causing this, all this microvesicular steatosis, these drugs, tetracycline, valproate, aspirin, and all this thing. And the commonest one, that is the alcohol, usually causes macrovesicular steatosis, macrovesicular steatosis. So all these following agents are implicated in microvesicular steatosis like tetracycline, valproate, aspirin, but actually alcohol commonly causes this macrovesicular steatosis and not your microvesicular steatosis. Yes. Yes, moving on to the next question. Caseation necrosis with Langhans type of giant cells is a feature of? Yes, guys, I used to discuss many times about this type of different types of giant cells. As you can see from our notes, a separate section on the different types of giant cells were discussed. And as you can remember from our notes, physiological giant cells, yes, osteoclast, megakaryocyte, and syncytiotrophoblast. Okay, these are all the physiological giant cells. And also one of the again repeated question is measles, that is the Barton-Finkelday cells, yes, and other cells, that is the classical owl-like appearance in Hodgkin lymphoma and Ashcroft giant cells in rheumatic heart disease. So all these things are actually pathological giant cells. And guys, as you can see from here, our notes, the characteristic multinucleated giant cells, that is the Langhans type of giant cell. Why you call this Langhans? Because you can see this horseshoe-shaped arrangement or a necklace-shaped. The nucleus is arranged in a horseshoe-shaped or necklace-shaped arrangement, and such giant cells are called as Langhans giant cell, and they are characteristically seen in our tuberculosis. And guys, do you remember the two-ton giant cells? What is this two-ton giant cells? These are all the multinucleated cells, as you can see here, multinucleated cells, and will be having this cytoplasmic vacuolations. They will be having this cytoplasmic vacuolations, and these are characteristically seen in dermatofibroma and xanthoma. Guys, as you can remember here, in case of any suture material or talc, such foreign materials, this foreign body multinucleated giant cells will be there. So, guys, let's see this question. Caseation necrosis with Langhans type of giant cells is a feature of? Yes, obviously it is a tuberculosis. Yes, tuberculosis is also a cause of this caseating granuloma. And guys, do you remember what are the causes for the non-caseating granuloma? Obviously, you'll remember non-caseating granuloma, remember this sarcoidosis, Crohn's disease, Hodgkin lymphoma. These are the common causes for this non-caseating granuloma. Tuberculosis very rarely can cause non-caseating granuloma, but usually it causes this caseating granuloma. So this both the things, caseation necrosis and Langhans. So both this points to a diagnosis of your tuberculosis. Tuberculosis. Yes. Moving on to the next question, purpura fulminans occurs due to the deficiency of the following except. So purpura fulminans like a clotting as well as this a case of like a hypercoagulability and also the necrosis of the skin. So all this occurs the deficiency of the naturally occurring anticoagulants. Yes. So that is the purpura fulminans, okay, essence of the hypercoagulability. And as you can see from our discussion, we have discussed in our workbook about this natural anticoagulants, natural anticoagulants. So what is this natural anticoagulants? So mainly it is the, as you can see from here, protein C and protein S. So what is this protein C? Protein C, it is actually is degrading the factor 5 and factor 8. Remember guys this discussion? Protein C degrade factor 5 and factor 8. So what will happen if protein C is deficient? Factor 5 will not be degraded, factor 8 will not be degraded. So what will happen? So the level of factor 5 increases. a clotting factor level increases. So it will naturally lead to a case of hypercoagulability. Then what is the role of this protein? Yes, protein yes acts as a catalyst in the reaction in which protein C degrades the factor 5. Protein C degrades the factor 5. In that reaction, this protein S acts as a catalyst. So what will happen if protein S is not there? Again, factor 5 is not degraded properly, and again level of factor 5 increases. So there is a sense of hypercoagulability. And also you remember factor 5 laden mutation? Factor 5 laden mutation, what happens? Factor 5 gains some resistance. Why I should always get degraded by this protein C? Let me show some resistance. Like factor 5 is showing some resistance, that is a factor 5 laden mutation that also causes this hypercoagulability. And also coming to this other option, this actually occurs. So purpura fulminans occurs due to deficiency of protein S, protein C, and also antithrombin 3. So what is this antithrombin 3? Antithrombin 3. So it is against the thrombin. So it is against the thrombin. So what will happen? So it actually prevents the hypercoagulability nature. But what happens here? Deficiency of antithrombin. There is no one to counteract thrombin. So what will happen? Thrombin level will increase. So obviously there will be a sense of a state of hypercoagulability. Yes. So protein C deficiency, protein S deficiency, and antithrombin 3 causes the hypercoagulability. Coming to what is this antiplasmin? Guys, do you remember this thing? What is the role of plasminogen here? So plasminogen converts plasmin. So plasminogen is getting converted into plasmin, and this plasmin actually will be degrading the fibrin. Yes, you can see from our notes. This plasmin will be degrading the fibrin into fibrin degradation products. Yes, so this we saw in our class. So plasmin causes fibrinolysis. Plasmin causes fibrinolysis. So what will happen? Antiplasmin. Antiplasmin. So antiplasmin is against. So somebody is obstructing the plasmin. So fibrinolysis is not happening. Fibrin is not being lysed. So that is a state of hypercoagulability. But what the question they have asked? Deficiency of antiplasmin. So what will happen here? If there is no one to counteract this plasmin, so antiplasmin counteracts the plasmin, but there is deficiency of antiplasmin, no one to counteract plasmin. So plasmin does its job very happily. So there is increased fibrinolysis. So in the deficiency of antiplasmin, there is increased fibrinolysis and there is no hypercoagulability. So the correct answer here, antiplasmin deficiency will not cause purpura fulminans. And obviously, the deficiency of protein C, protein S, and antithrombin will cause a state of hypercoagulability, resulting in the purpura fulminans. So as you can see from this discussion, guys, and I have shown you everything with the proof that all the questions were asked from exactly word by word from our notes itself. So I hope you enjoyed this session. Okay, wish you all the best, guys. Thank you.